But we're mostly going to focus on sort of the acute within the first, hopefully, day or 2 or 3 or 4 fractures. So we know for this injury, 2/3 of all elbow fractures in kids are supracondylar. So no matter where you are in the world, you're going to see a lot of supracondylars of retained care kids. These tend to happen in the 3 to 10-year-olds. They're usually a fallen and outstretched arm. The vast majority of them are extension types. So that's what we're going to talk about mostly today. About 2% are flexion types, which we now consider sort of like as a treatment when we talk about type 4 supracondylars, which are multi-directionally unstable ones. That sort of includes our fixation techniques for flexion types. I have to show this.
Slide show.
Oh, sorry, friends. Thanks. It looks great on my screen. Okay, perfect. Here all the time, we take care of multiple of these a day at our center across the Bay Bridge here. And families are always like, well, what's wrong in my child's bone that this happened? Like there has to be something wrong with them. And it's like, nope, it's just that anatomically, right at that level, in order for our hinge joint of our elbow to work, the olecranon has to have some place to go, right? And so we know that whole back side of the humerus is basically like open so that it can take the olecranon. So it's very thin already. And then when we land on it with force and that olecranon hits it, it easily snaps off. So it is just an anatomic risk area based on the width of the bone, which is very narrow at that level. Okay. The best and easiest classification in all of orthopedics, which is the Gartland classification. So the residents, this is like the best one, right? Like how easy is this? So type 1, 2, 3. We will talk about a 4 in a second. And this is based off the lateral x-ray anterior humeral line, right? So if you draw a line down the anterior aspect of the humerus, normally it should bisect the capitellum unless the child was very, very young. And we could talk about that variation later. A type 1 fracture is when we're broke in the front. We have an anterior cortical break, but it's not significantly angulated back. A type 2 is when we have that anterior cortical break and it is hinged back, usually such that the anterior humeral line is no longer touching the capitellum. And a type 3 is when the two pieces of bone are no longer like congruous, right? So they're not in continuity. In recent years, there's been this talk of a type 4, which is a fracture that you think is a type 3, but you take it to the OR and you try to do the reduction and it flips into flexion. And it's multi-directionally unstable. We call that a type 4 fracture. And our technique for that has to be a little bit different because of the instability. That classification system, like we just talked about, is based on the lateral x-ray and how displaced the capitellum is relative to that anterior humeral line. But probably what's more important is whether or not it's in varus valgus or in normal alignment. So we talk about supracondylar humerus fractures and whether or not we need to do surgery and whether or not our surgical intervention is good enough to leave the operating room. We talk about Bauman's angle, which is the angle along the long axis of the humerus and across the lateral condylar physis. So this angle in most children is anywhere between 64 and 82 degrees. It's not this little angle, it's this big angle. And so it's the 64 to 82. And so leaving the operating room, if you are sitting in 90 degrees, if you have a Bauman's angle of 90 degrees, you're leaving that child in varus. And they are not going to be very happy with your surgery, right? And so we need to think about both our alignment on the lateral view and our alignment on the AP in terms of deciding whether or not, 1, we need surgery, and 2, if we are good enough to pin and leave the operating room. So we know for our type 1s that we're going to treat these in a cast, and that's all we need to do for those. Type 2s, we saw a very big shift in this country over the last several decades to operating on all type 2s, closure reduction and percutaneous pinning. We now know that we shifted way too far surgically on these, and we're sort of pulling back a little bit on some of our indications. But if they are in extension, the historical treatment for this was a cast that looked like that, right? Which is a hyperflexion cast. And a lot of these kids that you put in hyperflexion would get Volkmann's ischemic contracture or compartment syndrome, right? And so we shifted away from treating these just in cast. So we would close, reduce, pin, and cast. And so then we had a lot of kids that were getting close reductions and pinnings for for not even that displaced type 2. And so thankfully, a voice of reason has come through our literature, or particularly down in Los Angeles, this group has done a number of studies that have looked at type 2 fractures and basically are showing that non-operative treatment is appropriate when it's an isolated extension deformity. So without varus valgus, if it's just extended, you can do a reduction and put them in a cast, but not hyperflexion, right? And then you do have to follow them to make sure that it doesn't extend and become unacceptable in its alignment. But they don't, if they're not in significant varus valgus, if they're just extension type and you can get that extension deformity to reduce, then they are fine in a cast. If they have a significant varus or valgus component, then we would do the standard closed reduction and percutaneous pinning, right? And from our perspective, a type 2 fracture usually just needs 2 wires. One is never enough because it doesn't control rotation. So we tend to do 2 pins for a type 2, 3 pins for a type 3, etc. So this is our type 3 fracture rate, are completely displaced with no cortical contact. They can have a significant amount of rotational malalignment or just be a nice extension type. They can also have comminution. 20% of them will present with a nerve injury, so a good neurovascular exam is going to be really important. This is sort of the classic type 3 that we're going to take to the operating room, close, reduce, and pin. So we'll talk about that technique in a second. Something to be really conscientious about, particularly if you're seeing these kids acutely, is this whole idea of antecubital ecchymosis and puckering. So if you see a child who's fresh from injury, just fell out of the tree, just fell off the boda, whatever it might be, they're coming in and they're significantly deformed with this amount of ecchymosis and puckering. This for us is something that we're going to take to the operating room relatively urgently to avoid any problems with blood flow and nerve function. Classic reduction maneuver, right, is some longitudinal traction under general anesthesia in the operating room to bring the fracture out to length. Obviously, the later you are from the time of injury, the harder that might be, just like we were talking about with the femurs. But if it's an acute within a couple of days fracture, you're ideally going to be able to pull the fracture out to length and get it out on the AP view. And then you do your reduction maneuver where it's longitudinal traction and flexion of the arm while manipulating the distal fragment up and onto the shaft, right? So literally that's my maneuver to get that fracture where it belongs. If you have 2 people, then it's helpful for one person to pull and do flexion and the other person to do the reduction. If it's just you, then you do this one-handed technique that they're showing you there, okay? If you have a acute injury and it's significantly displaced, that shaft can be through the soft tissue. So you're going to milk down the brachialis to deliver it distally while pulling longitudinal traction to get the shaft to fall back out of that brachialis where it's buttonholed. And then once it's out from the muscle, then you can do your reduction maneuver and bring it into alignment. Okay. When we talk about pin configuration, there's really important things that like pins matter in terms of where you put them and how you position them, right? So what are some things that you guys think about when you think about your pin fixation? What's your goal for putting your pins in? Yeah.
I need to do crisscross K-wire.
Okay. Yep.
Because when the training, it is like,
Yep.
it's a step around when they come from the
Yep.
side.
Okay. Yep. So cross pin technique.
Cross-pin technique. The question of the nerve injury is at a pin, but never experienced the arm nerve injury. So
Right. You're a lucky man.
I go crisscross, and because I don't have the CME, when doing seasons of the time, I do them open.
Yep.
Fracture, I do them open. Almost all of them.
And you're doing it open through what technique? What incision?
Lateral. I mean posterior.
Posterior.
Posterior
Yep.
incision, then I reduce, then
Okay.
I put the pins. And I find them okay. There are guys who are doing from lateral axis on the top, spread them.
Yep. So pin spread, right? So pin spread. What's another thing that we think about when we think about our pins? Divergent. The fractures both spread at the fracture site and divergent. What's other things we think about?
Basically, the criteria is when you place 2 lateral pins, when they cross a fracture, they should have been
the distance between those pins should be 1/3 of the whole width of the bone.
So pin spread.
Yes, pin spread is according that.
Because if two pins are within 2 millimeters of each other at the level of the fracture site, they are biomechanically one wire, right? So that's something that we have to think about. So it's number 5 on this little list, right? So we've done our longitudinal traction, we've done our milking maneuver, we've reduced our distal fragment onto the humerus. We can, if we have fluoroscopy, obviously this is assuming that we're using fluoroscopy with K-wire fixation. Every one of those wires needs to be bicortical. If you have unicortical fixation, you're not rendering very much stability to your fracture. So making sure that you're bicortical in your fixation, that you have good pin spread, meaning greater than 2 millimeters at the level of the fracture. The wider they are, the better, right? The more stability that they give, and they need to be divergent. The biggest thing is making sure you engage both fragments, right? So that seems obvious, but it's very easy in kids to miss the distal piece and you slide right behind it. Or you're in the distal piece, but you miss enough of the proximal piece to actually render yourself any stability. So making sure that you're engaging both fragments well and that a bigger wire if possible, right? So in the older kids, we tend to use 2 millimeter K wires instead of the 1.6 millimeter K wires because the thicker the wire, the greater the stability. And then once you're fixed, then you want to assess your stability, and then we're going to immobilize, remember, in nothing near 90 degrees, so less than 80. Your pins are holding your fracture stable. Your cast is protecting your pins. So it's not that you put some pins in and then your cast is going to hold your stability. If you're not stable with those pins in, you haven't done the right thing for that patient, right? In terms of our intraoperative imaging, right? So these are our pre-op images. We pull it out to length. You really want to make sure that you're doing good AP lateral and column views, because here you're checking to make sure you have good pin spread, that you're divergent, that you're bicortical. If you just look at this AP, you can't tell that this proximal wire is out, right? But when you get a column view, you can see that you are bicortical, and you want to make sure that you have bicortical fixation with all of your wires. To my friend's point in the back, so medial pinning, what used to be obviously the technique that most people used, but because of the concern for ulnar nerve injury, people started to move sort of away from more medial pinning. So there's been lots of studies in the US that have looked at this. The original study that sort of looked at lateral pinning versus medial cross pin technique did not abide by the principles that we just talked about. The pins were too close together, so they biomechanically were like one wire going laterally. When that study was repeated with good pin spread, good column engagement with the 3 lateral wires, the fixation stability is similar to medial cross pin technique. So, but if you like cross pin technique, that is okay. And there's certain fracture patterns where, like, if the fracture is very high, or if there is comminution, like sometimes you can't get 3 good lateral wires in, so you have to do a cross pin technique. In my hands, if I do a medial wire, this is sort of what I try to do to minimize my risk of nerve injury, but the studies haven't necessarily shown that this guarantees that you won't have a nerve injury. But I try to do the lateral wires first and then extend the elbow, which obviously brings the ulnar nerve away from the humerus. I do a small little mini open right at the level of the medial epicondyle and put a little retractor in to sort of pull that soft tissue back. And then I put my pin into my medial epicondyle where I can see it specifically and know that I'm not in the nerve. If I have a drill that allows for oscillation, then I put the wire across oscillating. Not everybody has a drill. If you're using like a Black & Decker, it doesn't necessarily have an oscillation feature. But if you're using a surgical drill, then you can oscillate it across. And if you're oscillating, then you're not going to pull any of the soft tissue up around your pin. Okay. So those are just some ways that you can try to minimize your risk of an ulnar nerve injury by doing that. And then for type 4s, which are these multi-directionally unstable fractures, or flexion types, which are harder to do because of the way that they're positioned and because they too are usually unstable, then there's sort of some different technique that you can use, which we'll talk about. So this is an example of a type 4 where you just knew it was going to be bad because here you're looking at an AP of the humerus and a lateral of the distal fragment. So you know that it's rotationally off and pretty unstable. When I went to reduce this, it flipped into flexion. And so then I'm going to use a joystick technique where I'm going to put 2 pins into the distal fragment. And then if you have this luxury of being able to move your C-arm from top to side, right, from an AP view to a lateral view rather than moving the arm, then you can use those K wires to sort of pull the distal piece where you need it to be. And then once it's in alignment, you hold one of the wires and put the other wire across, and that helps you get fixation of what is a unstable fracture. Because if you're moving the arm like this and the really unstable fractures, the bone will just keep twisting and you won't get it. And so you need to be able to move your C arm if you can, right? So making sure that you're optimally set up in your OR to be able to do that. And then this is sort of what that would look like in terms of treating a type 4. And then this is just an interesting comminuted one, which we don't really have time to go through. And kids are amazing in terms of how they heal. Flexion techs, we just sort of talked about that, right? So that it would be that same technique of putting 2 joysticks in that distal piece and being able to use that to modulate where how you align the fracture. All right. And then just real quick on nerve injuries, remember that in type 3 supracondylars, 10 to 20% of all children with a type 3 or 4 supracondylar will have a nerve injury. And so making sure we look very closely for that, because if it was there before we operate, we don't have to worry about it. If we didn't know if it was there or not, then we have to assume we caused that nerve injury and have to go back and take down our fixation and explore that nerve, right? So making sure the residents did get good exams, that we never take a kid to the OR without making sure that those nerves are working is really important in the pediatric orthopedic world. To the 2 residents that are in the room, I assume that, the attendings all have the faculty all have their ways of doing this, but it's very simple in kids to get them to play Rochambeau. I think we do that all over the world, right? Everybody plays some version of rock, paper, scissors with kids. So median nerve, radial nerve, ulnar nerve, and then if you can give an okay sign, then your anterior interosseous nerve is working, right? So I play rock, paper, scissors, okay with all my kids, and that's how I get a good exam, okay? So, and then obviously the importance of a actual intact AIN versus a not intact AIN. We know that the incidence of these are high, that they are neuropraxic stretch injuries. They are not tears of the nerve. And so as long as we get that bone fixed and stabilized, this nerve is going to start to recover. But in kids, it takes 6 weeks to 6 months for these to come back, right? But it's important for us, particularly when we don't have a lot of resources available to us, that if it was there before we did anything, it will very likely recover on its own, and we don't need to do anything other than fix the fracture, okay? And where the shaft goes is what does the injury, and I won't belabor this point too much, right? But if the distal piece goes posterolateral, the shaft goes anteromedial, and it's going to take out our median nerve, predominantly the AIN branch, but it can be median nerve proper or AIN. If the piece goes posteromedial, the shaft goes anterolateral, it takes out the radial nerve. Classic teaching is that the median nerve AIN is like the most common injured. They're not that different between median and radial, so just be careful to not just check the median nerve. The radial nerve can often be injured as well, right? So this is a anterolateral displaced shaft, so it takes out the radial nerve. This is going to be an anteromedial displaced shaft, so it takes out the AIN. 6 weeks to 6 months, educating the family and holding ourselves calm is going to be the most important thing. Vascular injuries we could talk about over lunch, but in the interest of getting to Dr. Saberwal's talks, we'll just acknowledge that, remember that if it's pink and well perfused, but not palpable, it doesn't have to go into the middle of the night type surgery. If it's dysvascular, it needs urgent surgery. And we could talk about that sort of, if you see this in your center and this is something that you want to talk about, we can talk over lunch about the management of sort of the pink pulseless and what to do in the OR if you do or do not get a pulse back. All right. And if we're going to open, we could talk again about various open techniques. If you do not have fluoroscopy, then most people are comfortable doing a posterior approach, because you can sort of see everything. Remember, though, if you're doing a posterior approach on a type 3 supracondylar, you're taking down the only attachment that bone has to itself, right? You're going through the periosteum, which is the part that's intact in a type 3 supracondylar. So we tend to talk about maybe going more lateral or medial. So if the shaft is anterolateral, you do a lateral approach because it's the shaft that's stuck. If the shaft is anteromedial, perhaps you do an anteromedial approach. And for us, if you have fluoroscopy and you can't get it as a closed reduction, we do an open approach. So the same incision that you would use for a fasciotomy, right? So you do the medial side here, come across transversely through the antecubital area over the mobile watch. So I always draw this out for my residents, and then you just use that little transverse limb to get in. And usually if you can't get it reduced, it's because that shaft is stuck on some muscle. And so if you do that little mini open, put your finger or a freer in there and you sweep the muscle away from the shaft spike, usually it will fall back in. And so you don't have to do a big open approach. Again, that's predicated on having C-arm in the room so that once you shift that out, then you can get it reduced. But if you don't have C-arm, theoretically, you could do an open approach here and you can move the muscle side to side and check your reduction and get it that way as well, depending on what your level of comfort is. All right. So if you don't have fluoroscopy, you don't have access to an OR, just acknowledging that we have traction available too. John Okore was actually the first person that taught me about olecranon traction back in the day. We know that non-operative treatment is an option and has to be in many places in the world, but this study out of Malawi showed us that, non-operatively treated type 3s don't do very well. And so if we have the means to fix these folks, we should. And so if it's an option, then please do try to fix them. This study, as well as some others, sort of show some important techniques. And then the late presenting supracondylars, which we'll talk about in a second, if it's a malunion, there's a lot of literature, but if it's sort of later presenting and it's not fully healed, but partially healed, what do we sort of do for that? There's not great literature on this. And so if any of you are seeing a lot of these in your centers, it'd be great to get some research going in this area. So supracondylar osteotomies for post-traumatic deformity are not part of my talk, but they are my colleagues. And so we will go there. I do just want to remind you guys that we have a bunch of educational information on our websites, the IGOT portal and Global Help. So if you want to ever access any of that, then you can do so through those QR codes.